All right, we are now at the question and answer session. And feel free to use the mics on either side. Looks like Rich has a question, so I won't have to use mine. Thank you very much.
Rich Shilsky from ASCO, and I'm not going to talk about the ASCO value algorithm. It's clear that the pressure's on. I did have a question for Patricia, though, about the value-based pricing, which, conceptually is certainly very interesting. And I just wonder your thoughts about the feasibility of its implementation, particularly in cancer, where, drugs are typically introduced into the marketplace after study in patients with advanced disease, where the value is likely to be the most difficult to demonstrate. And secondly, where the comparator may often be best supportive care or placebo. And therefore, it's difficult to know, what the incremental benefit is compared to the prevailing therapies that, are otherwise available. Then, of course, over time, experience grows with the drug. It's tested in earlier stage populations. Its true benefit may be revealed, but not until many years later. And so it's got to be difficult to figure out how to sort of be continuously adjusting the pricing as new evidence becomes available in new patient populations. Just curious to hear your thoughts about that.
Well, needless to say, I don't have any magic bullets. But I think that, to the extent that the patterns are consistent across drugs for how the uncertainty resolves, that there may be the potential for using some sort of modeling within, and then planning for the price to adjust within certain parameters over time, and revisiting it at defined periods. The one good thing I think that we have going for us is with the so-called big data mining. I think the evidence is going to become more readily available. It may not have all the nuances of outcomes that one would like, but things like survival, and it won't have the functional status, I guess, to the extent we'd like. But I think some sort of measures will become available. So some combination of post-launch adjustment and using modeling initially at launch to get to an approximate right price, I think would be a reasonable way to go.
Anybody else want to comment? Yes, please.
Mark, first let me tell you that I'm kind of mad at you for the peanut butter and jelly, because it takes people's mind off the omeprazole, the candy bowl. All right, so I'm taking it personally. But so, even a dumb oncologist like me totally gets the VBID for high-value services. So help me understand the VBID for low-value services. I'll let you define low-value services.
So you certainly don't want a general internist defining low-value services for oncology, but Michael, in the discussion about VBID carried programs, that your plan sponsors want to bend the trend, much more so than they want to see the quality gap and the health improved. And we deal with this tension all the time. And it was largely the employer community said, for me to allow low-cost tamoxifen and low-cost Gleevec and low-cost statin and insulin, you need to give me trade-offs elsewhere. And the timing couldn't be better, because as opposed to my saying I don't want a general internist picking, we now have something called choosing wisely, which when I said it the first time, only about half the people nodded, but half the people are sleeping. So maybe everyone knows this when I was talking. But the fact that we now have over 50 specialty societies starting the dialogue about these low-value services, and the American Board of Internal Medicine Foundation and Consumers Union has been extraordinarily explicit about the fact that these conversations in this program will have nothing to do with payment and/or benefit design, which is why I'm not afraid, as you know me well, to be in there saying I'm going to use this absolutely to start a conversation about payment and benefit design. And we're starting to look at some of these tools that, as opposed to Kevin's great presentation about arguing about service number 502 and 503, that there clearly should be a very positive benefit design for services 1 through 100. And those at the bottom, 750 or so, or 450 down to 502, should probably be different from those. The good news is that my colleague Michael Chernow, and there's lots of researchers around the country who are looking at services that not only viewed as cost inefficient, as Professor Danzin would say, but are services that are either designated as a D by the U.S. Preventive Services Task Force as harmful, or determined, like professional societies like ASCO, to say in trials that, for some reason, some harm to some people, these things actually harm them. And in our early analyses of common things, like obviously a complicated area, but prostate cancer screening, which is now a D rating by the U.S. Preventive Services Task Force, can pay for a ton of those high-value services that, Stacy Dutzine and other people would tell me that are being underutilized for even a $50 cost share. And I love that Dr. Newcomer's back in the room because while some people view a $50 cost share as something, they should probably pay that. In my patients and my work with the underserved and disparities, people can't even pay a $1 cost share. And that our ability to make drugs and Medicaid from $1 to $0 has really led to substantial 2 to 8% increases. So I turn to ASCO and I turn to COA and I turn to the patient advocates and there's a really nice piece in the paper today that we have to start understanding that more care is often not better care. And that's not should be driven by the payers. That should be driven by the patient advocate groups and the consumers to understand that sometime the right thing to do is to just stand there and do nothing. And that's, and I'll just address it, Kevin, since you brought it up, as someone who is also, if you Google me, a death panelist, and also someone who's been challenged on the floor of Capitol Hill as a rationer. My response to that is I ration harmful care. And if you do not want me rationing harmful care, then I think there's something wrong with the discussion. So we can start on the edges, right? Not in the middle where the folks in Oregon have been broiled for a decade, but those things where we are fairly confident that the evidence shows of a lack of value or potential harm to individuals. Start there.
Of course.
But when you say ration the harmful care, do you mean charge more? And if so, you have to look at, is that a patient-driven thing or a physician-driven thing?
So, we could spend a lot of time about this. This idea of it's not rationing when it's a service that's going to harm you. I need someone in the audience to help me with semantics to say taking the path to avoid that service is not rationing anything. I'm guiding you to the path of better health, which is what I am trained to do. I'll just say this. I personally are libertarian enough that if anyone wants to spend their own money on things that they feel that they will help their personal quality and length of life, that is completely fine with me. And I'm sure in many situations, particularly in oncology, you will find a provider to provide that. We are increasingly more and more being put in charge of being stewards of the collected good of a scarce resource. And because we are having more and more, if I understand the pipeline, in the diseases that Kevin put on the list, these high value, high cost, high benefit situations that we're ultimately going to have to make greater and greater conversations. And the fact that it's almost 5 o'clock, and I think we've avoided the word Solvaldi till 4:55. I think that I love the earlier presenter. This is not a new discussion about talking whether something that's expensive that creates a lot of health is worthwhile. And I think that you said it so eloquently, Shelley, that we just have to ultimately have this dialogue to understand that we cannot provide all services equal to all people. And one very, very tiny way to get this conversation going is to understand that patients may need a tool to say, if it's really good for you, your insurance coverage should be good for it. And if it's not really good for you based on the expertise that you provide at ASCO, Rich, that you could have it, but you might have to pay a little more for that.
Can I just add one more thing? Because you made the point about the copay, the small copay. And I heard somebody in the room say when that was being discussed earlier, well, I can't believe that's just 10 Starbucks. Well, for you and me, that might be 10 Starbucks, but I think for some of the patients we're talking about, that's whether they have food for their kid or for themselves because they're going to feed their kids, or whether they have, can buy school supplies for their kids. So I think we have to be careful about how we look at that. What may seem like a small copay is a lot to some people, and that's why I think some of your suggestions make a lot of sense in terms of these drugs that we know are going to help people, and we don't want to limit them because of copays that they can't afford.
Right. The fact that you said it makes sense, I should shut up now, but I just want to, outside of oncology, tell you an unbelievably fascinating story in these underserved populations that it turns out that because of the high level of economic security in the underserved populations that I think most of us care a lot about, that the rates of ER visits and hospitalizations for hypoglycemia, too low blood sugar, often brought about excess medication, occur in vulnerable populations in the second half of the month where their subsidies for food run out. So sometimes they don't take their medicines like they should. Sometimes they actually continue to take their medicines when they don't have food on board, and it leads to complications that I don't think any of us would have considered, these socioeconomic medical interactions that we're seeing now in these unbelievably vulnerable populations.
Thanks. Question?
Yeah, Alex Bastian here. My question is actually for Shelley. I just wanted you to reflect. You said through half the day you were a little bit shocked. I wanted to hear after this panel how you felt, but before that I'll piggyback off something Rich said, and it goes back to Patricia. I think that what you described is really the cost per quality, the British system, and from my perspective it's failed multiple times. 30,000 was the limit. They raised it for end of life. They created a cancer drugs fund when that wasn't enough. And they've done just about everything they can. They've weaned off a lot of success and a lot of R&D in the market. So I'm wondering, in a fragmented system where there's not a single payer, how is that actually reality, and how would that actually work?
State mandates about, that all plans have to cover all drugs, which are a significant obstacle to this. There's no intrinsic difficulty with individual health plans having as part of their criteria for a drug to be admitted onto a formulary to say that the drug has to meet their value threshold, and that would influence the price that they would be willing to pay. The way that the implementation might actually occur, very likely would be the manufacturer would have a list price and then negotiate discounts off of that, rather than name different list prices, which obviously creates all sorts of opportunities for arbitrage by the wholesalers. So it would be just like the discounting system that already occurs, but where a manufacturer is not, through the use of either discounts or various cost or risk-sharing programs, willing to meet the value threshold for that payer, that drug would not be covered. Now, some plans are beginning to do that and say we have a closed formulary and these things are not covered for these formularies. So we are seeing some beginning of that. But it's not explicitly linked to a value threshold. The proposal I'm putting forward would explicitly link it to a value threshold. Just to go to your prologue, this is the UK system, and that's been demonstrated to have failed. It's not the UK NICE system in that the threshold value and the way that outcomes would be measured would be to be determined in the US. For sure, we would pay a much higher threshold value than the UK does. We already pay at least twice as much per capita on healthcare as the UK does. So our thresholds, our benchmark prices would be much higher. And as I said in my closing comments, I would not expect this to affect our price levels. It would affect the rate of growth of new drug prices, and over time would encourage innovation more geared towards demonstrating the sort of outcomes.
Thanks for that. I mean, my comment was more that manufacturers haven't changed their behavior in the UK. 99% of drugs are rejected. So what makes us think that they would change their behavior in the US if we did it here too?
First off, it's not true that 99% of drugs are rejected in the UK. It's a much smaller percentage. Generally, there is restricted coverage. I think, as Chalkidu pointed out this morning, it is a real problem for other countries that the US prices are so high, which makes manufacturers reluctant to sell at lower prices in other countries, which are at lower incomes, have lower willingness and ability to pay, because of the concern that the US will then say, well, if you sell at that price in Europe, why are you charging us so much? And so there is a much bigger problem, I think, of rejection of drugs in the UK and Germany and other countries, precisely because manufacturers are reluctant to sell at a lower price than the US price.
Question?
Hi, I'm Cindy Gagan, a patient advocate, and I really appreciate that we're ending on a positive note and talking about solutions. But here's what I learned today. I learned I need to buy a candy dish and I need to fill it, and I need to have my peanut butter and jelly together because sometimes I like them separate. But the other thing I really learned is we do not have the evidence for a lot of these solutions that we're talking about, and we do not have transparency. So for example, if the MD Anderson model were to work, I don't know, not to put you on the spot, that we would share that with Sloan Kettering and Johns Hopkins and Duke, et cetera. It's just not the way we do things. How do we incentivize the collection of this evidence that we're going to need? And should we tie that maybe to participation in research and clinical trials to collect the data to get reimbursed or something? Because we're not going to move forward without this information, and I don't know who's going to pay for that.
I appreciate your comments. I think as we engage more patients, and we move to this era where patients are engaged in their care, both from deciding what treatments they want to helping us sort of formulate the future, I think we have to get to price transparency. And I fight all the time. You saw my slide didn't have any numbers on it. I fight with our finance people that there is no shame in telling people how expensive our care actually is. But we need to get to a point, and there is a lot of pressure about price transparency. I want it to be transparent, though, about true costs, because right now, if you share data about costs, it's so perverted by the cost shifting, people can't make heads or tails of it. I think we need to measure the costs of care the way it really is. And I do think whether we're going to be legislated into that or not, we have to be able to compete on price. And if our price is higher than, where's Peter, than Memorial's, you're going to have to decide, do you really want MD Anderson care or do you want Memorial Sloan Kettering care? But the caveat is you've got to also know what the outcomes are. And we cannot compare institution to institution on aggregated outcomes. There's a huge furor, and I think Peter knows this, of comparing the PPS exempt cancer centers' outcomes, and how do you compare, so we've got a long ways to go before we can get to that ideal world where you can compete on outcomes and price. But that's where healthcare needs to be. We've got to get away from these mysterious boxes of, I'm the doctor, trust me, I know what to do, and some third party payer is going to pay for it. We have to know our outcomes. We have to measure our outcomes. We have to publicly report them. And the whole public reporting system now in cancer care is absolutely abysmal. It relates to processes of care, and the PPS exempt centers we were told in the Affordable Care Act we had to report on outcomes of care. And when they went back, they found that the National Quality Forum has really no meaningful outcomes of cancer care, so they threw up a bunch of stupid process measures. We've got to transform that. This is 5 to 10 years of work, but we have to be honest about being able to publicly report our outcomes, compete on our outcomes, and compete on price.
I just follow up 2 quick points on transparency, for which I'm a huge supporter of. The first, and I think is very important given the large amount of attention, particularly price transparency is getting. Just because you know the price doesn't mean that you should buy it. And I think the entire transparency discussion has lost that, particularly as we get into homogeneous interventions like knee replacements and colonoscopies. And until we get these outcome measures and clear aspects of clinical indication or clinical nuance, I think that's important. And the second, and I don't know if it was Yusuf or whoever showed the slide, is that with the exception of people in high deductible health plans, for those of us who do not face these whopping deductibles and have some type of more standard coverage, the price that still matters to the patient making the decision is the amount that comes out of their pocket. And of all the slides I saw today, whoever showed that one slide that showed that there's currently a health plan that encourages patients out-of-pocket costs to go to or get the drug or get the procedure, I don't remember, that was substantially less than the other place, really suggests that this peanut butter and jelly thing is wickedly and wackedly out of control. And I think that if we could go back to some of these basic things, as transparency is good, but doesn't tell me if I need it, and if my physician is going to be incented for something, I should probably be incented to do the same and the converse of that.
Jeff Ward from Edmonds, Washington. My question is primarily for Dr. Feely. You pointed out in kind of your summary the biggest barrier to wide adoption of your plan, and that would be that until we're all merged into 11 big national cancer providers, figuring out how to do this when you have different groups, particularly in private practice, would be extremely difficult and a battle over the limited funds. But my real question relates to the disease you chose. So you chose head and neck cancer, which is a cancer that has a high cure rate. It's a cancer that uses radiation therapy and surgery as its primary modality, has limited drugs that are used in it, and the course of therapy is fairly short for most patients. Do you really think this is a plan that you can then extend and utilize in a disease much more like breast cancer, where a patient's course may go on for years and years at a time? It's much more heterogeneous in the population and in the treatments that are going to be utilized.
That's a great question. We had to start somewhere, and we started with head and neck cancer because the payer that we were working with also didn't want us to get into the space of dealing with colon cancer or breast cancer or large groups. But next up, we have lung cancer, and we're going to get into again the chemotherapeutic aspects of lung cancer. I think it's going to be more and more complicated as we get further along in all of this. But we felt we had to start with something that was definitely manageable, where we had a group of clinicians who were willing to embark on this, and we had a payer who was interested in working in that space. But you're absolutely correct. But what we also want to build are the systems to be able to track the patients and to track our economic performance so that we know how we're doing and how our patients are doing. No question, when we get to those larger, longer disease treatment bundles, that we're going to have to break these down into different elements. But the straight answer is we had to start somewhere, and head and neck was also something that wouldn't put us, so that we could get our finance people to agree to do it, wasn't going to put a whole bunch of our business on the table. And so we decided to start small. But for us, we also wanted to start in areas where we thought we had an edge in outcomes. And we really want to focus on areas where insurance providers are going to feel that they're getting good value by working with us as we develop these pilots. So we've got an awful long ways to go.
Rich, I'm going to take moderator's prerogative, doing a little audience scan, and give you the last question.
Thank you. Rich Shielski from ASCO. So questions for Kevin. I just want to be sure that I understood something that you mentioned, which I think you said was that in Oregon, coverage is contingent upon the similarity of the patient to the clinical trial population that produced the evidence in support of the therapy. And that seems to me to be a pretty high bar to get over, since the majority of patients seen in the real world don't qualify for most clinical trials. And so I'm wondering if you want to elaborate on that. But my real question is whether the system will allow for adaptation based upon real-world medical evidence as it becomes available. So, you know, a serum Medicare analysis or an observational data set that suggests that patients who would not have met the eligibility criteria still benefit from the treatment, would they then be covered? Or conversely, you know, what happens when the incremental benefit in the real world patients is actually less than the evidence that's demonstrable in the clinical trials, which of course will often be the case?
Yeah, very good question. On the latter, we have an evidence grading process that helps us decide what levels of evidence should carry more weight than others, and it's not just randomized trials. And I think what I wanted to communicate was that conceptually, the idea was the closer you are to what was on the trial, the more it would make sense to cover it. And so the real thing we wanted to do was to have a rationale for making performance status be an important, perhaps maybe only the important indicator of whether we would cover because there didn't seem to be any argument over that. The patients with very poor performance, we had arguments over whether you were disabled coming into the whole experience should matter or not. And there's some evidence that some folks who are frail medically may not fare as well. And the truth is, when you look to say, will they fare as well will they have an outcome that's what the trial predicted, we honestly don't know because they wouldn't have been on the trial. But the general idea was that if we could call out performance status as a key indicator, that would be perhaps maybe the only objective right now that we could use to justify denying care.
First of all, I wanted to respond to your question about did I hear anything that, I think that we all probably heard some things that, could possibly work. I don't know that we heard the solution, and there's obviously for each of the different solutions you all presented a lot of challenges to implementing it in various settings. So I think that there's obviously still a lot more discussion to be had. I wanted to ask Dr. Feely a question, and first I also want to say just that the percentage of people who are able to choose between MD Anderson and Memorial are probably very, very small. Those people are in a lucky position, but I don't think that's most patients. But can you tell us a little bit about what is the patient impact on these bundles that does the patient see a difference in their cost when they're in the bundle? Or you said that the providers don't necessarily even know that they're in the bundle, so how does it impact the patient and how is it communicated to the patient?
No, in fact, we're just working out those details with the payer, but the aim is for them to have the same co-payment structure as they previously had, but the patients will definitely know that they are in a bundle, and we will have a special patient service coordinator to coordinate their care that would be identified and a 24-hour phone line staff, so that if there's any wrinkle whatsoever, and also to encourage them to get their care with us. But you're absolutely right. We don't share too many patients with Peter for obvious reasons.
Well, they come from MD Anderson, they don't go back.